the communities team, and this is the launch of the Arab Community Health Profile to understand the health needs of the Arab community. So next slide, please. So the agenda today, so we've got a short introduction and then going into the overview of the Arab community. After that, we'll have the Arab Community Health Profile, so discussing the key findings from each section of the report, suggested actions and key notes. And then we'll be having the incorporating findings, so our key takeaways, how we're incorporating data into practice, learning and reflections. And then finally, the engagement opportunities, so our next steps for engagement and upcoming funding opportunities, following with a Q&A and closing statements. Next slide, please. So just a little bit of housekeeping before we set off. So please stay muted and turn off any VPNs. If you have a question, use the Q&A or the chat functions in class, in the chat. You'll get the slides via email, and all the slides decks will be uploaded to the BCC website. And finally, the webinar is being recorded. So if you're not happy with your face being captured, please have your camera turned off. And we will be using Menti throughout the session, so we'll have the link in the chat now. So if you go on to menti.com or use the QR code, the code for the actual Menti session we popped into the chat. Thank you, Jordan. So that's 52471779. We will have some questions throughout the session, including some longer answer questions. These will be put into the chat so you can have a think throughout the session before we ask those questions at the end. So next slide, please. So just to start everyone off, the first question, so what's one thing you're looking forward to learning or discussing in today's webinar? So I'll just give you a second to have a think with that. Just checking if everyone got the Menti. Okay, we can come back to this. I think the chat response will be left open so you can fill that in at any time. So if we can go on to the next slide, please. So just a short introduction to the community health profiles. So the community health profiles are a key set of resources developed by the Public Health Division at Birmingham City Council. These reports look at summarising the physical health, mental health, lifestyle, behavioural and wider determinants of health-related issues in the community. The profiles focus on specific communities of identity and support in a shift away from using terms such as BAME or LGBTQ, which often homogenise communities together and often overlook huge differences in health outcomes between population groups. So the full reports and additional resources are found on the Community Health Profile homepage, with further information on the research in this webinar being found specifically in the Arab Community Health Profile report. And we've also produced an infographic summary which condenses the information in a bit more of an accessible view. And for more information on the background and research methodology of the profiles, you can watch our Intro to Community Health Profiles video. I think Jordan's popped all of the links in the chat so you can have a look on there. So next slide, please. So onto the data collection for the Arab Community Health Profile. So we used information from the 2021 census. The Arab ethnic group was included in the top 20 ethnic group subcategories within the other subgroup. And there were other considerations we need to make when using this data. So data that are relevant to the experiences of Arab people may include country of birth, length of residence in the UK, and English proficiency. So the health needs of recent Arab migrants with limited English language ability will be significantly different to someone with an Arab ethnic group background who is born in the UK or Birmingham and speaks English as a main language. And it's all important to consider other aspects of someone's identity in tandem in healthcare or community settings to avoid assumptions that people which belong to one specific ethnic group will all have the same needs. Next slide, please. So there are some data limitations. So there is an aggregated ethnic issue with aggregated ethnic categories. So people under Arab ethnic groups are often categorised under the other ethnic group category instead of their own. There are inconsistent results, so an inconsistent use of ethnic group categories inhibits efficient analysis of health and wellbeing needs. And data from the GP patient survey and the GPPS and health survey for England have not been adjusted, so this leads to unadjusted variables. Next slide, please. So this is just a demographic overview of the Arab community within Birmingham. So the population size is 46,391, which makes up 4.1% of the total population. The population within England and Wales is 637,217, apologies, which makes up 1.1% of the total population. For the Arab community in Birmingham, 92% of Arabs identify as Muslim, and they have a largely young population, with 27% of Arabs aged 14 and under, and 53% under 25 years old. And as you can see on the right-hand side is a age breakdown of the Arab community against the general population. So you can see it's heavily skewed towards the younger ages. With the national identity of people of the Arab community being 58% identifying as British only, in contrast to 63% of the Birmingham average, and 35% identify with a non-UK identity only. Within the Birmingham population, the largest specific Arab ethnic groups include Arab, which is 20,485, which is 1.8% of the population, Somali, which is 21,584 people, making 1.9% of the total population. Smaller ethnic groups in Birmingham do include Sudanese, so 1,678 people, and other Middle Eastern, 1,684, and Moroccan is 317. Next slide, please. So the overview of the geography of the Arab community in Birmingham. This information is really useful for us to know because place-based community events or health interventions can vary within the community. So we use the census mapping tool, which uses ethnic group available data to output area, which is the OA, and it uses MSOA. The MSOA density of Arab ethnic group ranges from 0.1% to 16.4% within Birmingham. Output areas relate to the smallest of the geographies that data is published at, and have an average population of 310 residents. MSOA relates to middle super output area, so an area containing roughly 2,000 to 6,000 people. So you can see this breakdown on screen. By population density, Balsall Heath West contain the highest density of the Arab community at 15.1%, with Sparkbrook and Balsall Heath East having 8.2%, and Broadsea and Highgate with 5.6%. And 2,238 people in Sparkbrook and Balsall Heath East were Arab. Next slide, please. So on to our second Menti question. So how do you currently use health data to inform your work or decision making related to addressing health inequalities? So I think the Menti code is still in the chat and you can see it on top of the screen. So I'll just give it a couple of seconds to go through. Okay, so no worries. We'll go on to the next slide, and again, the questions will still be available. So how confident do you feel in identifying the health needs of the Arab population? Okay, so yeah, we've got one in the middle. Okay, that's a great start for us because that's in the middle. Hopefully we can increase that. So the start of our health data, so we'll be starting off with getting the best start in life. For this section of the webinar, in nature of time, we will only focus on one key piece of data from each section of the report to show the types of findings. Where possible, we will highlight the best quality of data by using large-scale studies or national databases. The slides will not provide a comprehensive understanding of all the health needs relating to the Arab community, and instead offer a start point to conduct further research. And it is suggested that the attendees read the full profile and any cited data sources for additional reading. So we'll start with maternal health. So the total fertility rate, TFR, was 3.9 for women born in North Africa and 2.6 women born in Middle East. So TFR is defined as the average number of live children that a group of women would bear if they experience the age-specific fertility rates of the calendar year in question throughout their childbearing years. This essentially refers to how many babies each mother would be expected to birth. So a TFR of 4 would indicate an anticipated 4 children. So as we can see that it's slightly higher in the Arab community than the UK born. There's an increased risk of gestational diabetes within the Arab community, so there's an approximate prevalence of 13%, with confidence intervals varying from 11.5% to 14.6%, with the national average in England being 5%. So gestational diabetes is a high blood sugar glucose that develops during pregnancy, and it usually disappears after giving birth. It can happen at any stage of pregnancy, but it is more common in the 2nd or 3rd trimester. The Arab women were identified as high risk in a 2015 Embrace UK report, especially those with heritage in Saudi Arabia, UAE, Iraq, Jordan, Syria, Oman, Qatar, Kuwait, Lebanon, and Egypt. And a 2021 systematic review showed the highest in Sudan at 23%, with this varying between 3.3% to 45.2% in the confidence interval. So this might not be reflective due to the large size in that. There are barriers to accessing maternal health care. So this was based on a UK-based study of Arab Muslim women, and other smaller UK studies showed similar findings. So the main barriers were found to be language barriers, racism, discrimination, prejudice, unfamiliarity of UK services and how to access, and misalignment between expected services and services received. Next slide, please. So mental wellness and balance. So smoking, people from Arab and other ethnicities were the least likely to use smoking cessation tools such as e-cigarettes and nicotine replacement therapy. In a cross-sectional study of UK adults, which included 132,000 people, 20% of people from Arab or other ethnic groups were current smokers in comparison to 18% of the study average. The odds of e-cigarette use for cutting down and temporary abstinence from cigarette use was 42% lower among those from Arab or other ethnicities, with an odds ratio of 0.58, varying between 0.4 and 0.83, compared to those of white ethnicity. Shisha is commonly used within the Arab community, so between 4% to 12% use reported in Arab countries. It's also referred to as water pipe tobacco smoking. In a water pipe, tobacco is placed on a small ceramic stove covered with tinfoil and fired with charcoal, and the smoke is passed through a water tank before inhaling. The practice is associated with lung cancer and COPD, and use is typically viewed shisha as less harmful and addictive than cigarette smoking. A systematic review of 38 studies found that many Arab countries had high prevalence of shisha, so 4% in Gulf states ranging up to 12% to 15% in Lebanon, with group smoking being popular, so 15% of the Egyptian population reported social smoking, and studies have shown that the safety shown is no safer than cigarette smoking. Next slide, please. So healthy and affordable food. So there's limited information on obesity prevalence of the Arab population in the UK. International data from 2011 suggested overweight and obesity prevalence to range from 25% to 38% in men and 28% to 83% in women in Arab countries, with contributors to obesity being genetic predispositions, lack of physical exercise, and food culture and diet. So BMI is calculated as weight in kilograms divided by height in meters squared. BMI does have limitations such as no consideration for ethnicity, age, sex, or stage of development. And it's suggested that for Arab adults, BMI threshold for obesity should be set to 26.6 kilograms per meter squared due to risk of diabetes at lower BMIs than people from white ethnic groups. Grade 1 obesity is currently classed as a BMI of more than or equal to 30 kilograms per over meter squared. Next slide, please. So active at every age and ability. So data was taken from the Active Lives survey from 2016 to 2018. In England, 52% of people from Arab ethnic group were classed as physically active. Which was in comparison to 60% of all adults in England. High rates of physical inactivity, so less than 30 minutes per week among Arab communities, which was 35% of the population, compared with people from other ethnic groups. Barriers to physical activity could include access to easy and affordable physical activity resources and religion and culture. The definition of physical activity can vary within the Arab community. So, for example, Saudi students considered physical activity as all types of activities, including walking, domestic and work activities, or going to the gym, while Somali women saw it as a structured activity involving high-intensity planned activities like sport. Religion and culture play a part of this, such as the availability of single-sex spaces and female instructors, embarrassment or fear of harassment whilst wearing modest sportswear. However, these experiences reported less frequently in the UK than other European countries, such as France and the hijab ban. And awareness of physical activity programs and facilities was also a barrier. So this was also associated with language. So facilitators included physical educators who speak Arabic, tailoring of health promotion materials. Next slide, please. So living and working well. In the census, household deprivation was defined as a household is classified as deprived in the housing dimension if the household's accommodation is either overcrowded, in a shared dwelling, or has no central heating. 37% of people from Arab ethnic group in Birmingham lived in a household classified as deprived under the housing dimension in the 2021 census, in comparison to 11% of white British. So overcrowding is one of the main part in this. So 35% of people from the Arab ethnic group lived in overcrowded households according to the 2021 census, and within Birmingham, in comparison to 7% white British. So this is defined by occupancy rating of bedrooms being -1 or less. Private rented or socially rented, so 41% of the Arab Origin households in Birmingham rented from the private sector, compared with 23% of all households in England. Private renters on average spend a higher proportion of household income on rent compared to other tenures, so either social rent or owner-occupied. Areas of deprivation, so the top 10 MSOAs of Arab ethnic groups in Birmingham are all in the top 20% deprived neighbourhoods nationally, with 6 being in the top 10%. And barriers to housing and services, 22% of people from the Arab ethnic group in England live deprivation under the barriers to housing and services domain, compared to 11% England and Wales average. This includes geographical barriers such as physical proximity to local services, and wider barriers including affordability of housing. Next slide, please. So protect and detect. There's limited information available on the Arab population of the UK. However, some sources indicate potentially lower vaccination uptake of certain vaccines. These include the COVID-19 and influenza. With COVID-19, by December 2021, 28% of the Arab population in Birmingham in the 65 to 80 plus range had received the booster dose. In comparison, 87% of the white British population. With influenza, in a 2021 study, low uptake was reported among eligible Arab populations, so 43% with a confidence interval of 39.6 to 46%. In comparison, the white British population had an uptake of 57% with a confidence interval of 56.9 to 57.2. Next slide, please. And ageing and dying well. So the EQ5D index is a standardized measure of health-related quality of life. So this includes mobility, self-care, pain or discomfort, anxiety and depression. Outputs in the study range from 0, so value of death, and to 1, which is perfect health. Health inequalities are apparent in all ethnic groups other than white British, with Arab men having a score of 0.71 and women 0.6. In England, experienced worse health than white British men, which was 0.77, and women 0.75. Poorest health was rated as a minus 0.594 score. This was less than 0, so represents a health status value worse than death. This isn't applicable to the majority of the population. The ethnic inequalities associated with these scorings include increased prevalence of long-term conditions or multimorbidity, poor experiences with primary care, insufficient support from local services, low patient self-confidence, and social deprivation compared with white British group. Next slide, please. Contributing to a great, green and sustainable future. So Ministry of Housing, Communities and Local Government, they mapped pollutant data with geography data from the 2021 census, and approximately 15% of the Arab community lived in the 15 most polluted MSOAs in Birmingham, in comparison to 5.4% of the white British population. Air pollution is a major public health risk, and estimated that 6.2% of total mortalities in Birmingham were attributed to particulate air pollution. The pollutants in the air can include nitrogen oxide, benzene, sulfur dioxide, and particulate matter. Next slide, please. So other key inequality data and conclusions, we've gone through quite a few different things, but these are just other key inequality data that we wanted to include. So this includes the prevalence of childhood obesity, hesitancy to seek mental health support, poor experience with GPs and primary care, and experiences of hate crimes and discriminations. So our conclusions from the Arab community health profiles, that it's important to highlight that inequalities are often compounded by intersectionality. So example, Arab people with a disability or long-term health condition often experience worse health outcomes than those without a disability. And the community health profiles provide us an evidence summary to start building co-produced solutions. It's important to note that the community health profile is not a fully inclusive document that will accurately map the experience of all Arab people. It should just be used as a starting point. Next slide, please. So just to check in now to see how confident do people feel in identifying the health needs of the Arab population following the health information. So I think we were on 3 before and we've gone up to 4, 3.5, that's still good improvement. I think we're going to the next slide, please. So opportunities for engagement, the profile review. So there are potential areas of feedback, so appropriate language used throughout, community area of importance not included. The profiles all follow the same outlined template for sections or subsections. Therefore, if there is a health need or key community identified area of importance is not being included in the profile, please let us know. We can add this in the final report version. Missing data set or relevant reports, and general comments and feedbacks. The profiles are all currently in their draft version, and all webinar attendees are encouraged to read the full report or area of interest in the report. Organisation details may be added, so if your organisation works with the Arab community or you offer a specific health service for the Arab population, we can add your contact details in the report appendix with your consent. So please email the communities team at birmingham.gov.uk, and I think that we put in the chat. Feedback can either be given in writing the community's inbox, or you can book onto a feedback session, which we will confirm the dates with to discuss. Next slide, please. So the opportunities for engagement, so to disseminate findings. So we encourage the use of the community health profiles as a start point for developing services and interventions. So the profiles typically only offer headline data on each section due to the breadth of information covered, and you should use other sources of information, including internal intelligence, to support future projects and interventions. So have you shared the profile with either team members, wider organisation, partner organisations, or community organisations with our people? Or have you used the profile by referencing the profile in a new project, including findings in projects or service proposals, influencing discussions with relevant stakeholders, or making your daily practice more inclusive? Next slide, please. So how do you envision incorporating the findings and insight from today's discussion in your work or organisation? So you can submit your answer on Menti. So we've already had a great one. So to better our education, to improve our approach, that's brilliant. Okay, I think we'll go on to the next slide, please. And in what ways do you hope to see healthcare services become more inclusive and supportive? So just give that a moment. Okay, we'll go on to the next slide, but I think that should still be available on Menti. And what other intelligence would be helpful to inform your work or improve your practice? Okay, I think we'll go into the next slide, please, but that will still be available on Menti for you to submit. So we have opportunities for engagement. So we have our engagement partner programs. We have one lot available of funding for the Muslim community. So this must include projects in collaboration with both South Asian and Arab Muslims as a minimum. So it's not specifically for the Arab community, but the Muslim lot does include funding that must go towards projects in collaboration with Arab Muslims. It's a 2-year initial contract plus 1 year for extension. It's part of our to be a deep engagement partner, and the project is focused on sustainability and upskilling as a core outcome. And Jordan just popped the link to the tender in the chat, so if you are interested, you can go have a look into that. The timeline for the deep engagement partner program, so the tender is already live, and it closes on the 8th of May. The evaluation and award period will be from May to June 2024, with the anticipated contract commencement being in July 2024, with the initial contractual period until July 2026. So if you are interested, please go look into the tender, which has been popped into the chat by Jordan. Next slide, please. So what does the Deep Engagement Partner Programme involve? So you would run focus groups, 4 per year per lot, produce a qualitative summary report and disseminate outcomes. Public health engagement will include 5 times attendance to the council forums per year, and disseminate public health messaging, that you'll be working towards a health inequality project. So 1 significant project developed per year, co-designed with the target community. And then you'll be working with e-learning, so community leadership training, to deliver 4 training sessions on cultural competency to healthcare professionals per year, and supporting the BCC Champions programme. Next slide, please. So we produced quite a few webinars since February. All of the previous ones will be going onto the YouTube channel, which is the Healthy Brum account. We have one more session going ahead this week, which is the students aged 16 to 24 session. So that's 11 till 12 on Thursday. So you can sign up on Eventbrite, and I think the link has been popped into the chat. So please sign up. Next slide, please. So do use the community health profile, so you can scan the QR code on the screen or use the link, so you can have your say in making them better as we're working to improve them to better meet your needs. So please take the University of Birmingham City Council Community Health Profile Evaluation Survey. So all of the replies will be treated confidentially. So if you're happy to go ahead with that, please use the QR code and you'll be taken to that form. Next slide, please. So if we don't have any questions, I think we'll go on to the next slide, please. So this is just some key contact information. So the communities team inbox, so if you do you want to message us, that's been popped into the chat. The community health profile homepage, that's available on the Birmingham City Council website, and the Healthy Brum YouTube channel, where all of our previous sessions have been uploaded to. You can also sign up to our mailing list, so that has updates on future events and funding opportunities. And also please complete our feedback form for this webinar to help us improve. These links have all been popped into the chat by Jordan, so you can go ahead and have a look through them. Next slide, please. And these are just the links and references for further reading from the session. This has just been taken as snapshots from the community health profile, so please go ahead and read the full report, and there'll be full referencing on there. Next slide, please. Yeah, more references. I think that is the end of the session. I'm not sure if anyone has any further questions. We can stop the recording if anyone wants to ask anything whilst not being recorded.